Hello everyone, we are going to show laparoscopic rectopexy done for complete rectal prolapse. If you take treatment for rectal prolapse, we have got abdominal approaches and perineal approaches. In general, laparoscopic approach gives better long-term results and it is associated with lower recurrence rate. We create pneumoperitoneum by using carbon dioxide. The pressure is 14 millimeters of mercury. The patient is in Trendelenburg position. So that the small bowel loops will fall into the abdominal cavity. You can appreciate the deep pouch of Douglas. In order to get better exposure, we are lifting the uterus anteriorly so that the dissection will be done with a good exposure. The first step is to identify a plane between the mesorectum and the pelvic fascia. Once you enter into the proper plane, you make sure that you stay in the same plane until you complete the dissection. While incising the peritoneum on the lateral side, you have to be very careful not to injure the ureter and the hypogastric nerves. Because of the repeated prolapse, these two structures may get shifted medially, so it should be prevented from getting injured. So now we extend the dissection deep into the pelvis, again staying in the same plane, and this dissection has to be carried out until we reach the levator anal muscle. So if you stay in the same plane, there will not be any undue bleeding and the extension of the dissection can be done in a better way. Now we come onto the right lateral side and we actually divide the thickened peritoneum, and that incision is extended anteriorly. After doing this, we are going on to the left side. Again, the dissection has been completed on the posterior side and the incision has been completed on the right side. Now we are coming back to the left side. Again, while doing this peritoneal incision, we have to prevent left ureter and left hypogastric nerve from getting injury. And after completing posterior and lateral dissection, we incise the peritoneum, which is grossly thickened, on the anterior aspect in order to get a plane between the vagina and the rectum. So alternately you can do the dissection on the right lateral side and left lateral side. You can appreciate the ureter here. Until you reach the pelvic floor muscle. The complete mobilization should be done in order to get the better possible result. In mesh rectopexy, you have got anterior rectopexy and posterior rectopexy. We normally do a posterior rectopexy. So you can see the plane which is coming out nicely, and we have extended the dissection up to the perineal body on the anterior aspect, and you can appreciate on the posterior side now we are reaching the pelvic floor muscle. You can see the levator ani muscles coming into view. So this is a complete mobilization of the rectum. That is the first step before actually doing the rectopexy. So if you do this complete mobilization, the rectum will get shifted cranially with a good traction. Another point is whether to divide the lateral ligament or not. If you divide the lateral ligament, the results will be good, but the incidence of constipation will be slightly more. We don't keep a very large mesh. Previously, a large mesh was used. Now we are keeping a smaller size mesh, and the mesh is fixed to the sacral promontory by using 2-3 stitches. This is a non-absorbable polypropylene sutures. While taking this bite, you have to be careful not to injure the iliac vein. So after fixing the mesh to the sacral promontory, we give a nice cranial pull to the rectum. With the cranial pull, we are fixing the lateral edge of the mesh to the thickened peritoneum or the thickened mesorectum by using 2-3 stitches on either side. And after doing this lateral fixation of the mesh to the rectum, then the final step is closure of the peritoneal opening so that the mesh will not be exposed to the intra-abdominal organs and there will not be any adhesions or erosion of the bowel loops. So this is done on either side. Normally we don't place any drainage tubes, and this step completes the procedure, and patient will be started on oral fluids after 4 hours and he will get discharged within 24 to 48 hours. You can appreciate the deep pouch of Douglas got obliterated, and we have freed the uterus, and this is the completion of procedure. Thank you very much.